This is what pisses me off. The toxic fucking environment that nurses have against other nurses. So...
And I'll see you on that.
That fucking pisses me off. Because the way that I look at it, when you become registered, your experience 2-3 years under your belt, you are not really required, but it's kind of expected that you share that knowledge and experience with the new upcoming nurses and try and help support them to become fully fledged, appropriate, skilled, competent nurses. You feeling ready? Feeling zen?
I feel ready.
In the words of Chandra, I feel like I'm in the moment. I'm not thinking about tomorrow. I'm not thinking about yesterday. I'm thinking about being in the moment.
In the moment.
So, man, how you doing?
I'm good.
Yeah?
I'm good. Enjoying the holiday.
I hate you that you're on holiday, honestly. And I say this every time you go on holiday. I'm like, I can't believe you managed to get holiday again. It's very hurtful. Very hurtful. But... we just released our first episode. Well, we've recorded our first episode, and we've got a question.
Yeah.
So maybe we can answer that now.
That sounds good.
So I'll pull up the question. So the question is basically, and it's an interesting question.
Yeah.
The question is, and it's from an anonymous. It's an anonymous question. So I'm not going to tell the person who asked the question. So we have two questions. One of the questions is, where is it? What does mental health care look like from a mental health nurse themselves?
Good question. Deep question.
It's a very deep question because it's kind of the whole premise of this podcast.
Yeah.
Right. It's kind of like talking about our perspective on the delivery of mental health.
Yeah.
What do you think? I mean,
what I'm thinking, if you don't mind, just read it for me one more time.
Yeah.
I can.
So the question is, what does mental health care look like for a mental health nurse themselves?
Yeah.
It's a deep one.
And I've got a feeling each nurse probably would have a slight different answer. Depending on, because one thing I noticed of mental health nursing is everybody has different experiences, different placements. Even though you work in the same setting, even your caseload is different. The people on your caseload, so that shapes you. Your past experiences to where you are and how you're practicing, and I guess influence your answer.
Pull the mic a little bit closer to you, my friend. I think that's get a little bit.
Cool.
That's it.
Awesome.
That's the one. Yeah. So mental health. What does it look like to us? It's in a way, like I thought it was a very straightforward question, but now that I'm sitting here with you, it's actually a very difficult question. Because what it looks like to us. I mean, we treat people with diagnoses of schizophrenia, bipolar disorder, schizoaffective, which is a combination of schizophrenia and a mood component. We treat people with depression. We see people with personality issues, antisocial, borderline personality, histrionic. I can just go here and name all of them. But we have a wide variety of different people. And my perspective of it is basically, it's hard as shit.
Definitely. See, as soon as you ask the question, there's two things that come to mind. How do you answer that question from a personal perspective, you yourself as a person? But then also, versus what's your expectations from them, or what's the expectations from your employer? Because your employer's expectations, like the DHB, for example, have what they call episodic cares, which automatically influences the care you provide.
Maybe explain a little bit to people what episodic care means, because I think that's a word that used quite frequently, and actually in all health settings, not just mental health. So did you want to explain a little bit? Episodic
definitely. Care? So my take on episodic care, which is kind of more coming from employers, kind of different from the employer, the DHB, is they use the word like a, you come in as a specialist service, as a person specializing in mental health, supporting that person on their journey of recovery. But basically getting people in the community, for example, community services like NGOs, family, involved to help that person long term live a life of recovery. So you, for example, have an aim point to discharge after all these kind of interventions and medication, all those kind of things come in place. And let's say, for example, so you have people kind of come in the service, all the specialized interventions come in, you do what you need to do, and then discharge. And that's where the GP takes the primary cares with all the supports. And then at the same time, people come in the service. So it's people come in, interventions take effect, and I guess discharge. So it's almost like a revolving door sometimes as well.
I was just about to say that. And personally, I don't like that view, because the revolving door and the way that it's explained is you do what you need to do and then you have them out, but you allow them to come in quite easily again.
Yeah.
Well, as I'm of the thinking, if we can do a job really well, we won't need that readmission or that return through the revolving door. But I think that opinion is a very hard one to maintain because that takes a lot of resources, a lot of time. And unfortunately, with our, having to care for up to 30 people plus on our caseloads, sometimes that becomes very difficult to manage, because in honesty, trying to follow up people with that amount of people on your case, you try your best to provide the best care as possible, but you're always limited for time. Because you need to finish this person, and then you've got to visit another person. Oh no, you've got to visit another person, and it's not that we're doing the bare minimum. I think we're trying to do the maximum amount we can within that time frame that we're given. And I find it difficult. I find it hard because we have that staffing issue. We talked about quite not extensively, but we did talk about it in the last podcast that staffing has always been an issue, and because of staffing, we have to have more and more people on our caseload, which means we have to split our time more and more for more and more people, So we have no choice but to sort of roll with this sort of idea or this model. It is a model, actually. It's a model of care, which is the revolving door. Now, I get it. I get it. If you had to put it down to resources and time, the revolving door makes sense. But then from a client's point, from what I can see, is that you come in and the next thing you know, you feel like you're being rushed out through the other door.
And, so for example, like you'll, as you say, have a high caseload, let's say 30 people, but then each week you get new referrals come onto your caseload, so it's a person you have to kind of get to know, form the relationship, see what's actually going on, how can you help, what's important, but then if you don't, for example, discharge, your caseload just gets higher and higher and higher, and then questions is asked, why is your caseload so high?
And it's like, then you're sitting there like, well, I'm trying, but it's not like we can just discharge people when they're not ready.
Exactly.
But then that's the question. When are people ever ready for discharge? Now, we have a group of people that are keen to get out of services, for whatever reason, whether it's they don't want to engage or they don't believe the system works, yada, 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 all these other factors. So you have that group of people. But you have another group of people that actually want to engage. They want the treatment. They want the supports. They want the therapies. They want the follow-ups. But at the end of it, you have to rationalize the interventions that you're giving. Is it effective? Is it not working? What do we do next? And recovery, and they tell you this all the time. They tell you this coming through nursing school. They tell it in your postgraduate year, that recovery does not have a time frame.
No. And it's usually so individualized, person by person. Each person has a different journey, and, so it's unique to that person, and
Absolutely. So how do you get someone out the door? And I don't mean that in a really bad way, like we're trying to kick people out of the service. But how do you prep someone for discharge when we can't really tell at the time whether they've had enough support or follow-up that's around them, Now, we can put supports around people, referrals to this, referrals to that, follow-up from external services to help, bring in an entire package of care. But sometimes that's not viable,
And what I've also noticed is even if you, for example, let's say the private sector NGOs comes in with community support workers or family and GP, everybody plays that role. A lot of people are hesitant to discharge from the service because they feel it's almost like a barrier of support, or not a barrier, it's an element of support. So they know that just touching base with you once in a while, it's on the right track, and so it's hard to discharge a person if they don't necessarily want to be discharged, or don't feel ready to discharge, but you're kind of like, fly a little bit.
That's the scary part. As clinicians, we have to at some point test that out. Test putting someone out there into the world with as much skills and as much supports as possible, and see what comes from it. Sometimes it doesn't go so well. Sometimes they do get referred back and they need extra support or top up here and there. And some people thrive. Some people thrive for years and years and never come back into the service. So it's trying to, but that's where it comes down, and you captured it really well, which is everything's very individualized. There's no sort of, we'll use this one intervention and that's going to be for everyone. Exactly. And it's cool. Everything needs to be patient focused, and that's the hard part, because there's so many different ways of getting someone to this point of needing discharge. But it takes time, I think. And that time factor is, I guess, the difficulty for us, because we get pressured from, is it fair to say pressure? We get
more expected, maybe expected.
Fuck it, it's pressure. It's pressure.
Pressure, yes.
It's pressure, that we have to move people on. And there's reasons for that. We have a limited amount of resource and we need to be able to spread that around as much as possible. So, yeah, it is difficult. So I guess to go back to the question, what does mental health look like for mental health clinicians? It is a long, drawn-out journey with multiple deviations in that path, with occasional speed bumps, a lot of fuckery, a lot of fuckery from this, that, and the other. But eventually, if everything goes as planned, and that's a plan in collaboration with the person that you're supporting. If that comes to fruition and goes as planned, there's always it's amazing outcomes that come from that.
Yeah. And like for me on a personal, so this is more on a personal viewpoint, I see it more me as, I'm going to use the word facilitate. So I see myself as facilitating the journey of recovery. So I, meet the person, and I'm a strong believer that each person has a different story to tell. It comes down to the nursing model, the title model. So basically saying each person has had a journey in life, therefore they've got a story to tell. And as a nurse, it's important to understand that journey, because that's where often a lot of the, trauma or the stress, or all those kind of things come. So if you understand that story, I guess the interventions and the support you put in place hopefully would be in a more effective kind of supporting that person. And then it's me seeing myself as facilitating it, walking side by side that person, to make sure that person is kind of, I guess I call it recovery, kind of recovering from, from the distress and
from
things
everything, from
like,
life. And it is life for a lot of these people. I mean, that's their daily life. So so that's your view.
Yeah.
So that's your personal view.
Yeah.
What's your professional view? Because a personal view, that's a dime a dozen. Everyone has a personal view on what mental health looks like. Everyone has their own journey, like you mentioned, which influences the way that they look at the world. But this podcast is focused on people that work within the system. So if you can, what is your professional view, do you think?
So professional view, it basically is supporting a person on their journey to recovery with the aim to make that person independent, with the treatment, taking medications and things, and, bringing in the correct supports in place. So that person eventually can be discharged and, I guess, supported in the community and family and friends.
No, that pretty much aligns with what I think too. It's not an easy journey for a lot of people, and some people are still on that journey 5, 6, 7, 8, 9, 10, 11 years on,
And how it makes sense, like it's, we've spoken in the last podcast, is even student nurses coming through, what is our role exactly, So I see it more kind of like they use the word, so I'm a case manager, which means I manage the case, so each client that comes in effectively gets a treating team. So it's a nurse and a doctor usually assigned. And, see, that's where you make sure, for example, the mental health acts are up to date, the prescriptions, doing the appropriate referrals, meeting that person on a regular basis, which is a bit more kind of a professional sense of support. But then how I see it is, yes, I'm a case manager, but I'm also a registered nurse. I'm a nurse specializing in mental health. So that's where, for example, it comes down to that mental health nursing as a speciality. Kind of doing discussions around, what is the diagnosis. Early warning signs, protective factors, stressors, all those kind of things.
The classic psychoeducation.
Yes.
Our favorite part of the job.
An assessment.
Which is trying to basically explain to someone that you have schizophrenia, but that person believes to their core that they do not have it. So it's like I find, now that I say it out loud in that way, it sounds ridiculous. And I think, we talk to a lot of people about kind of what we do. And it kind of segues perfectly into, and you mentioned students. So that kind of segues perfectly into the next question. So we kind of talked about, in the first podcast, about students being unprepared for their placement in mental health. The question is, why are students not prepared for placement here at knowing how difficult and confronting it could be?
Giovanni, so I often think, with mental health, it's so close to home often. I guess a lot of students coming through are triggered through, for example, what they experience on placement, whether it comes down to family violence, I guess, even things like addiction often plays a big part, and then it's all those things, people divorced, losing employments, accommodation, finances, and even a diagnosis like schizophrenia. If a loved one has something that is so impacting it, students coming through it can be quite provocative. On the other end, I also think there's a lot of stigma associated with mental health. So I guess a lot of people, for example, and that's what made me smile in nursing school, you have to practice to have conversations. And I thought to myself, why on earth would you practice to have a conversation? Still remember,
I can talk to people. I can talk to people.
I can remember sitting and practicing a conversation with my, the other student.
How
nurse.
awkward is that?
That is so random.
It's so awkward. So for people who haven't done nursing school, one of our assessments, because you went to a different nursing school to me, but one of our assessments through, I think the paper was called Therapeutic Communication. I don't know if they still run that paper now in the nursing school that I did, but it was called Therapeutic Communication. So that's basically teaching you how to engage with clients on a personable, therapeutic level, And part of one of those assessments is role play. And I fucking hate role play. I really, really dislike role play because it's either I take it too far or I'm not engaged enough. There's no middle ground for me. Like especially if I'm playing the actor, the person who's got the diagnosis and has to sort of respond to my colleague who's trying to do an assessment on me. So we have to do this assessment where a person would sit in front of you. They already have a script. You have no idea what that script is. And your job is to try and tease that out and ask questions and be personable while being recorded by a camera, which adds, like, if you were anxious before that, now you're extra anxious because there's a camera recording, but you also, there's a one-way window, one-way mirror. You know those mirrors that's in police movies where the suspect is in the interview room and then there's a mirror and on the other side the police officers are listening to them and watching them at the same time. So there's that. So, and we know there's other senior lecturers on the other side assessing you, and it is the worst feeling in the world. Like that is anxiety provoking, But they try and teach you how to have conversations, and it's a very different kind of conversation. It's like, you're talking with someone, but at the same time, you're trying to relate, you're trying to build rapport, you're trying to be respectful, you're trying to acknowledge the cultural differences and the cultural norms for them. And at the same time, you're doing an assessment. You're assessing them at the same time. So it's a skill.
Yeah, definitely.
It's a skill.
Yeah.
It's a skill / art
Yeah.
to it.
Yeah.
That's why they call it like the art of nursing,
Yeah.
as opposed to the nursing skills.
And so, so now you have student nurses coming through, after they, but then some of the I guess criteria is just to have a discussion with a person, on maybe somebody with schizophrenia or schizoaffective disorder, and just to have a conversation, talk about your day or anything. And I noticed a lot of student nurses get so anxious and so nervous, they basically just sit there and don't know what to say,
They
and they
freeze.
freeze. Yes,
Because it's confronting.
it's confronting.
I mean, imagine the students, for people out there, imagine you're a person coming into a placement for mental health for the first time, and your precept, either myself or LJ, tells you, it's your turn now. It's your turn now to go and do an assessment, Just have a conversation with the person, and obviously there's certain aspects we want you to assess and try and find out. And then to have like students, and it happens from time to time. A lot of them are actually quite good, Yes, they start quite anxious and then they start to build confidence as it goes on. But there's some that just sit there and freeze, and then it's like, oh, hello. What? How are you today? And that's the conversation.
Yeah.
And they just shut down. And I just think, oh,
Yeah.
man, their prep work. And I don't know if it's the prep work or just it's not that they don't get prepped. I just don't know if it's enough to get them ready for the kind of work that we do here.
And that's why I wonder if it's an element of stigma, because often you see these movies, that's quite out there. And then I guess if you don't have any experience in family or anything like that, it can be confronting. But I always tell the student nurses, don't let the diagnosis define the person. It's still a person. It just basically diagnoses kind of grouping a similar kind of symptom that. So it just and something I also say to student nurses, a lot of people have been in the service for many years and they've seen many students come and go, and I usually ask permission, or I always ask permission before, asking a student nurse to have a discussion. So it's nothing unfamiliar for a lot of the people we work with, but student nurses, quite scary.
It is. And like I said, it's very confronting. And you also mentioned it before. A lot of them, there may be a lot of crossover, a lot of things that may be a little bit too close to home, personal experiences, blah, 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 blah. But we all have that. We all have our history. We all have different levels of trauma. We all have our own anxieties. I mean, me and you have been working this job for so long, but there's still times where I get quite anxious before meeting with certain people or leading a group or leading a discussion or sort of being out there and sort of having to put myself out there, But it's finding that way to get over yourself and realize we're not here for you.
Exactly.
I'm not here for me.
Yeah.
I'm here for a particular reason, and it's to care for this client or to sort of figure out what we can do for this client. And I think once students get their head around that, and they start to understand a little bit more about this, okay, this is what I need to do. This is, it's beyond me. No one's actually giving a shit what I'm doing, We're actually focused on the client and trying to get what this person wants. And I think once they get through to that, and we've had plenty of students come through and they just evolve into this amazing sort of clinician. Some of them end up coming to work with us.
Exactly, yeah.
So it is, I think the prep is, it is there, but there's a lot of other biases that they come with which impact their initial view of mental health. Like movies, like the stigma, out there in the world right now, like news articles of a crazy dude doing this, that, and the other. Your preconceived ideas all play a part in sort of a person's ability to sort of engage,
And something I've also noticed coming through placement, so, when you do nursing school, you're exposed to different settings. You'll get, for example, mental health or addiction or, children or older adults. So different places just to kind of give you a taste of different settings. Um, and I've noticed sometimes preceptors make or break a placement. So, like for me as a nurse, I enjoy working with student nurses. I want them. I enjoy kind of helping them grow in that that profession. And sometimes even if you don't choose mental health nursing as a career path, but just having a good experience, just understanding a little bit more about that nursing, I think it's valuable experience for your future career. But then I also notice some nurses, for example, it's whether it's workload or what's going on at home or just a combination of a lot of things, not necessarily keen on precepting, but then is expected to precept student nurses. And I feel for the students sometimes because you pick up on these kind of things. So
they're the worst.
Yeah,
They're the worst.
Yeah, so
Now, I really enjoy teaching students because I gain a lot from it too, because it actually shows me what I need to learn up more about. Because you don't actually know shit unless you can explain it to someone.
Exactly. Yep.
And I get caught out a couple of times, and it's kind of like, oh no, I do know this, but just a refresher. I just need to refresh myself on certain questions. But I've got a story. It's a story time about how a preceptor actually almost broke me and almost decided that where I work now was not for me.
Yeah. Let's hear it.
So story time. So it was going back to my new grad year. I just started. I think my preceptor, I had met my preceptor that was going to take me for my first rotation. Very nice lady, talking, got along quite well. But she had to go on leave the following week. So I had a week of orientation, kind of got a rough understanding of what the services does and stuff like that. But still not a deep grasp, just kind of basically a superficial understanding of what community nurses do, community mental health nurses do.
Yeah.
So she takes a week off, and everyone's struggling to sort of find me a preceptor for the following week. So they give me to this nurse, I won't say her name, but you will know who I'm talking about as we go along. I'm sure a lot of people who I work with would understand who it was. So she comes across very nice, very mindful, very grounded, very experienced, which she was. Excuse me. Very experienced. And then she kind of tells me this, that, and the other. And then she goes, hey, I've got a doctor's appointment. Do you want to come sit in and experience what that looks like? I hadn't been in one yet. So like, cool. I'm keen to absorb all of this. Go down with her, have a chat. So when I sit in a slightly defensive sort of posture. So I kind of sit back with my hands kind of like enmeshed like this, like clasped together.
Yeah.
And I usually have my leg like folded over, so I'm kind of like sitting with my leg folded over. Hearing the doctor's appointments and just hearing everything, learning so much, seeing what the doctors do and sort of the interactions and the treatment plans and the deeper assessment and discovery and trying to find all these different aspects to help formulate a plan and a support plan. In between that, I find it hard to sit still. I don't know whether I've got some undiagnosed ADHD or some shit like that. Yeah. But, I switch my legs from time to time. Not all the time, probably like every 10, 20 minutes, I'll kind of like switch over. And then so finish that. I was quiet the entire time. I was sitting in the corner quite away from the assessment, but enough where I can hear and still be present. And then we kind of finish it off and then, thank the patient, the client for allowing me to be part of it and kind of we went back upstairs to the office. So this nurse comes and grabs me and pulls me in and says, I have to have a talk with you, a very serious conversation. And I was like, oh, okay. Interesting. Sure. Should we go into one of the meeting rooms and have a chat? No, we can just have a chat here in the middle of the office with everyone around.
Yeah.
And she kind of sits right in front of me, very, very like overbearing, like standover tactics in a way. And she talks to me about, during the meeting, you switched your legs over, 2 or 3 times during the meeting. The meeting was an hour long, by the way. 2 or 3 times during the meeting. And I feel that kind of disturbance could have really disrupted the therapeutic environment which I tried so hard to create prior to the meeting starting. So I think you need to be really mindful of that. So let's do some mindfulness exercises right here. And I want you to close your eyes. And so me as a student, being very inexperienced, very green,
Yeah.
is sitting there basically getting told off by this nurse. And don't get me wrong. It's not like the way that I'm explaining it. It sounds like she's trying to help, but her tone was very different. Her tone was very
Punitive.
very very minimalizing. Not trying to not supportive. Very, you fucked up.
Yeah.
You fucked up, and I need to fix this fuck up. And so we sit there for like another 20 minutes, and she fucking does this mindfulness bullshit exercise with me in front of everyone that's in the office. And everyone in the office is looking and wondering what the fuck's happening. And she kind of says like, oh, I know you've just started here, but maybe community isn't for you. Maybe you need to consider other options. And she kind of just left me to my own devices for the rest of the day. And that, to me, as a person who's never done community and starting out, and I'm trying to find a job, right? So the new grad year is you sort of being exposed to different areas of mental health, but you're not employed yet. You're employed for that year, but you have to apply for jobs after that year. So I'm trying to sort of set a good example or have a good impression for people. And she just fucking ruined me.
Man.
Absolutely ruined my confidence, my excitement for the job, and everything else that I was just trying to sort of just be a part of it. Now, I really seriously considered fucking moving. I really considered, just because me and you had just met, but we weren't really as close. I was just someone new. You were there like about a year before me. And I was just in the space of just absolute shit, because she was supposed to be a person that's supposed to help guide me and support and sort of get me prepped for the role. But she fucked that over majorly. And I was seriously considering to quit. And then I just told myself, listen, let's just get the week done, wait for my normal preceptor to come back, and we'll see how I feel as the 6 months progress. Because it's 5 months, 5 months stint here, and then you have another rotation and another 5 months there. So third week comes along, and my preceptor comes back, and then everything turned out great, and I'm really grateful that I ended up staying. Me and you have made a very close connection. We've continued to have a bromance for 7 years strong. But that's the power of your preceptor. They will fucking they will either make you feel amazing, confident, ready to tackle new challenges, and knowing that there is a future for you in that field, or they'll make you fucking leave nursing in part overall.
Career change.
Just fucking change your career and you become a fucking, something else, totally unrelated. You end up becoming a plumber, Not that there's anything against plumbers, but it's totally a different field from nursing,
And, I'm usually an optimist, so I see this, as, I guess traumatic as it was for you at the time, but I see it as a moment of experience. So I'm actually have a question is, do you think that moment influenced how you precept or tutor student nurses coming through today?
Absolutely. Definitely. Once you have a bad experience with a preceptor, you will try your best. If you're a good person and you genuinely care about, the students that you precept, you genuinely don't want them to feel that way. I would like to say I'm a very good preceptor. I've got excellent, not to toot my own horn, but actually I'll toot both our horns. Actually, we have had amazing feedback from our students that we've had over the years about the experience that they've had, the enjoyment, the amount of learnings that they've had, and you're right. That moment, and I remember it clearly still too, because I remember the embarrassment. The anxiety, the absolute drop in my confidence and my self-esteem, and almost breaking me. Man. And I remember that clearly. And this is like going back 7 years almost, But that did stick with me, And that has definitely influenced how I treat students, how I treat new grads, and who I precept,
Because how I see it as a preceptor, you help shape that student nurse, and the career forward. And feedback is important, but it should be constructive feedback, not necessarily making you feel like a piece of shit, or
which we could easily do.
You, yes.
That's the thing. The preceptor has so much power
because
that they can say one thing and you are fucked.
Yeah.
And then you have to
placement hangs on it,
But you have to drag your ass back in there every day to finish your placement, because it's a requirement. You have a certain amount of hours that you need to fucking finish.
Your story actually made me think of a story as well.
Hit me with your story.
Yeah, so it was also in the new grad year, my second rotation. Second rotation, but now my first community experience as a psychiatric nurse. And it was a nursing, like a nursing meeting, so nurses are kind of like encouraged to have nursing meetings once in a while, just to talk about some fun nursing.
Is this the monthly nursing meetings that we have?
Yeah.
Oh, okay.
And I remember, I'm new to the team and we're having a nursing meeting and I'm sitting there. But some of the topics was quite fascinating that the nurses brought up and spoke about. And I thought to myself, something I need to do is gain a bit of confidence, have a bit of a voice. Nursing is a practice, Giovanni. So, you keep practicing at the things you're not as good at, confidence, all those kind of things. And I thought, okay, I'm also going to contribute to the discussion, So I remember that my preceptor had 30 clients that, she was working with, precepting me, and I had 15. But the preceptor is responsible for the 15 on my cases as well, kind of having to oversee that. But the policy actually says if you're a precepting nurse, your caseload should be reduced so that you can compensate for, the person you're precepting. And that wasn't the case. So she had 30 people she was working with and the 15 on me. And so it was basically 45 people that, she had to kind of oversee and help me kind of along. And I brought that up, I brought that up as a discussion and things. Not necessarily to complain about it, just to kind of raise the awareness, because we were talking about workloads and all those kind of things.
Just a big FY fucking I for everyone in this fucking meeting. To know this is what's happening.
Yes. And everybody, received it well. I was glad I said, had my say. And the meeting finished. We all went back to our desk. So we've got an open plan office. So I went and sat at my desk. And as I kind of wanted to carry on with work, the team leader walked up to me and screamed at me in front of all my colleagues, like on the top of her voice, screaming that if I have problems with how she runs the shift, that I need to come and talk to her in person. I should not embarrass her in front of her colleagues. And red in the face screamed at me, and I remember just sitting there on my chair, kind of shrinking away. And then she turned around and walked back to her office. And still remember sitting there like, what just happened? I've never experienced this before in my life. Very embarrassed because all my colleagues are sitting there just looking at me. And how do I repair this? I'm coming through a placement. This is my team leader that I report to. I didn't mean to offend her by, at all. And I just remember walking up to her office and apologizing profusely. But thinking back on it, why I apologize this to, I guess it's more to dampen the fire, so that I don't get kind of, picked on or bullied or anything like that.
Or singled out.
Yeah, just to smother the flames. So I just went and apologized and, and I walked away from there feeling like this is so unprofessional. I don't know how this person even became a team leader. And that's why I asked the question. It influenced my practice. So, as a tutor, I would never scream at a student nurse in front of everybody. It's important that the feedback is constructive. That feedback was not constructive. So I guess that's something that stood out to me.
This is actually a perfect thing, because we were talking earlier about starting new segments of the podcast, and I wanted to start a segment about things that piss me off, right? So I think this is a perfect opportunity because you've just made me think of something which really fucking pisses me off.
Let's hear it.
This is what pisses me off. The toxic fucking environment that nurses have against other nurses. So...
And I'll see you on that.
That fucking pisses me off. Because the way that I look at it, when you become registered, you experience 2-3 years under your belt, you are not really required, but it's kind of expected that you share that knowledge and experience with the new upcoming nurses and try and help support them to become fully fledged, appropriate, skilled, competent nurses. So when you have someone who comes across you, and because you had a discussion or you brought up something, you know, something quite relevant even, that you got fucking screamed at in fucking front of everyone, that makes my story feel like a fucking pushover actually. But it pisses me off because it happens everywhere.
It happens.
It
It happens.
It's happened to me coming through nursing school when I had a good idea that I wanted to come into mental health, and I was pretty settled on it. And a common question you get asked out on the field as a student is like, "Oh, where do you see yourself? Nursing, blah 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 blah." And then as soon as you say mental health, they treat you like shit. They're like, "Oh, that's not real nursing. Oh, really? You're just gonna waste all your skills and go become a mental health nurse?" And it makes you feel like shit. When really, it should be the opposite. You should be encouraging people. Wow, that's an interesting field. Why? Why do you want to go there? Ask some questions about it. Don't just fucking shut us down and make us feel like pieces of shit, because it carries on. You see it in those really old school fucking nurses.
And that's what I wanted to elaborate on, Joe. I wonder, because you used the word old school, I actually wonder if it comes down to a form of hierarchy. Like nursing is an older profession. It's been around since I'm actually thinking the World War II, maybe even before that.
Florence Nightingale, brother.
Yes.
Florence Nightingale.
So there was an element of hierarchy there. So I can remember speaking to some of my colleagues saying those beds on the wards and stuff had to be made perfectly, otherwise there would have been consequences. So I'm wondering whether it's a form of hierarchy passed down generation. A lot of the younger nurses coming through now, especially now since the new grad programs came in place, don't have that intense kind of hierarchy or intimidating kind of old school type of, so that's just something I was wondering whether it can be a form of that, or is it just individualized burned out. I don't know.
If you speak to people who were trained before it became a mixture of practical and academic, and it was the nurses who got trained in the hospitals, lived in the hospitals,
and the old psych
trained on the hospitals, it was very militant. It was very militant, and I think that's where a lot of that comes from. You do as I say and do it exactly how I wanted, or else fuck you.
Yeah, especially the matron.
But that was the attitude. Now, not every nurse turned out that way. We know plenty of nurses that went through that and became amazing nurses. But that's because they moved on with the times.
Yeah.
They adapted, they evolved, they changed.
Yeah.
It's the ones that refused to fucking change, refused to fucking take on this new view of nursing, refused to acknowledge that you don't have to be trained in the hospital, that you that's what nurses are. Nursing has changed dramatically over the years, and I think those old school nurses see that dying and are desperately holding on to what they know and what they understand. And by doing that, they externalize their anger and frustration, and they shit on people. They absolutely fucking shit on people. I've seen it happen. I've experienced it myself, and that's why it pisses me off. Some of the fucking nursing culture out there is so shit. That's why we have a high case of bullying. There are fucking articles upon articles upon articles of fucking bullying in nursing school.
Yeah.
Not nursing school, sorry, but in hospitals by senior nurses, because a lot of them are just fucking assholes, and that's not who you want looking after your parent, looking after your brother, your sister, your grandparents.
And Giovanni, like, part of me, realized that a big part of your day you spend at work. And if you are in an environment that's positive and encourages you to be in a space where you're comfortable, and I think your work output, for example, the way you practice as a nurse, gets influenced, from your workspace. So if your manager is supportive and you're able to kind of talk about concerns and stresses and you feel supported, you can go out in the field and you can actually go and make a difference. Where if you feel bullied at work, you're not in a good headspace, and then you have to hold or work alongside people who's also struggling. it's not easy, you know.
It's bullshit. That's what it is.
Yeah.
I'm getting really animated and fired up about it, because it's bringing back my past traumas and it's making me angry. But I can't believe that person fucking walked up to you in the middle of the fucking office and screamed at you.
I know, but
not a stern talking to, not like a very passive aggressive conversation, but fucking screamed at you. Like I can't imagine. Like, I'm not a manager. I'm not a coordinator, right? But I know that that's not how you fucking deal with shit, And it must have taken you a lot of fucking power to hold back and just not turn around like, fuck, shut the fuck up.
Yeah. I think there was a lot of element of shock, to be honest, because
that's fair.
It was a normal day coming to work, and I'm sitting there. We just did this nursing meeting. I'm at my desk. It's a professional setting, and suddenly it's not a colleague or some, somebody dysregulate. It's my team leader, the person you report to, you look up to. She's kind of guiding the shift that does this. So it was definitely a lot of shock, just sitting there like, what just happened? It's so surreal, I can't explain it.
That's the person that's supposed to be leading the fucking team, Fucking hell. But then it's like, that says a lot more about her than it does about anyone else. That shows me a lot of anxiety, low self-esteem, just knowing that the only way that you can get your point across is intimidation and fucking shock and awe and screaming at a new grad. Not even a nurse that's been there for a while and sort of understands the dynamics, but a new grad who, all new grads are ignorant. They don't know the fucking culture. They don't know what to say, what not to say. All they want to do is get through their new grad program year, get a job, become a nurse, and fucking nurse for as long as they are able to.
And in your new grad year, you don't want to piss people off, especially your team leader, So
well, you want a job.
You want a job.
You know what I mean? You want a job, and that
employed.
team leader has a big say in that.
Yeah.
But that is not that's such a shitty working environment, bro.
Yeah, it was
I'm sorry that happened to you, man.
But Giovanni, thinking about this, it's the same as what happened to you, having to sit in the office space, everybody looking and doing mindfulness, in the quiet, holding hands. I don't know what that was looking like, but
it was not pretty. I can tell you that much, So, oh man, I don't know what I would have done. I don't know what I would have done if someone walked up to me, especially a team leader, and started yelling at me for nothing. No real reason for that.
And think about it, in a health setting as well, and not even my colleagues did anything. They all just sat there. It happened, walked off. Manager was there. You can't not see this or hear this, and and then you have this big movement saying bullying is not okay. And that same person would probably say that to you.
None of those people deserve to wear pink.
Exactly.
On anti-bully day, because if you're not doing a bully, if you're not saying anything about it, then you should you're just as bad,
But I'm very open to constructive feedback, because I think, if the team leader was insulted or pull me in the office, just have a frank discussion with me. You don't have to make a scene in front of a lot of people. I will definitely be receptive to feedback. But
that's a power play, though. That wasn't really directed at you, though. Doing that in a public area is actually a message to every motherfucker that can hear. That's what I think. I think she went out there with the purpose to fucking put you in your place, which is ridiculous, which is fucking ridiculous. That deserves a fucking complaint. Serious fucking complaint, almost like a human rights bullying, fucking take it all the way to the Geneva Convention complaint.
Conduct complaint.
Fucking hell,
But what I learned from that is how you speak to your colleagues, especially about feedback. It's important, it's impacting.
You have to be able to take constructive feedback though in this job, because you receive so much of it. you receive so much constructive feedback about what you need to do, what you haven't done, and what could possibly happen. And you have to be open to that. You have to be open to sort of taking that on board and adjusting. You have to be able to adjust the way that you do things, the way that you see things, because you don't know everything. You don't know everything. You haven't experienced everything, and you need to acknowledge the wisdom of people that's been there for a long time.
Mm.
You know, I don't know if people really respect our wisdom because we're kind of like the dopes of the fucking office, though, aren't we? But my point still stands.
Yeah.
You know, I think constructive criticism is important, and you know, and that's what I'm pissed about. That's what I am absolutely pissed about is the toxic culture, certain places of the nursing field. So beware people who are looking to fucking do nursing. You may or may not, but you may, highly likely may, run into some very fucked up people, you know?
I just wonder, you know, because it's public servant state settings, whether this is across all sectors, like police, you know, Tamaki Oranga, all those places, or is it unique to nursing, you know, like...
I think there's bullying everywhere, you know? But I think the nursing culture is synonymous for it. Synonymous? Am I using that word right? Fuck it, I'm using it now. Is well known for their bullying culture. And we kind of touched about a little bit about maybe the history of nursing, how it used to be quite militant, blah, 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 blah. But that doesn't make it okay. There's no reason out there that sort of gives you the right to fucking go up to someone and scream at them at the top of your lungs as an intimidation effect, you know? Fuck, I don't know what I would do if someone did that to me. Probably cry. You know?
To be honest, I'm actually wondering about it because now I've had, 8 years of experience. And I'm a strong believer that bullying is not okay. I'm fully employed though, and I'm not in a vulnerable position like what I was, kind of coming through internship.
But we're always vulnerable.
Always vulnerable.
Emotionally
I sometimes
vulnerable.
wonder to myself, how would I have approached that differently? You know,
how would you? That's a good question. With what you know now, your experience now, the amount of work that you've done with people, the amount of leadership roles you've taken, you know, preceptoring is a leadership role. Level 3, you know?
Yeah.
How would you respond if a team leader, let's say that same team leader came up to you and fucking screamed at you right then and there? What would your first reaction be?
Shock, probably, again.
Wait, is this happening to me again? Why is it always me?
I probably would ask if we can go speak in private, but I'll be calm, cool, and collected. Just to kind of, not have an audience, so you kind of remove that, power play kind of thing. In that moment, I probably will keep it brief. Just say it's not okay to scream at me. What's actually going on? Just to understand what's the concern. Afterwards, I'll talk to my colleagues, just to see some moral support. But I'll probably go through with a complaint.
Fuck yeah!
With a complaint through the DHB,
complaint
rather
system.
than through the team. Yeah, it's an incident.
Man,
but even that is stressful because she'll still be your team leader.
Yes, So the dynamics
and now
is
there's
different
a complaint in progress, so you need to have the inner resilience to go through with a complaint and have the appropriate supports to support you through that. And
the unfortunate thing would be, you would probably, if the complaint was taken seriously and then there was mediation and there was no way of actually coming to some form of resolution, one of you guys would have to move temporarily. It would be you.
It probably would be.
Which is sad.
Yes,
which is really unfortunate.
Yes, because I'm expendable.
Yeah.
Yeah.
Yeah. And that is a very tough fucking pill to swallow.
Yeah, there's many nurses out there.
There's thousands.
Yeah.
Unemployed too, desperately looking for work. And that's like I said, that's a very tough fucking pill to swallow. You do amazing work, and you like to think you are an important part of the team, but you are in no fucking way inexpendable. Unexpendable,
I think. So even
you are very much expendable.
It's because even a small example, if you don't have a practicing certificate and which is up to date, that next day you are not allowed to work or practice as a registered nurse.
Yes, not that it's ever happened to me ever. I have always been up to date with applying for my certificate every year. Yeah. Which reminds me, I need to double check when mine is next due. But yeah, it's a sad fact to know, because you want to feel important, you want to feel acknowledged for the hard work that we do, and we do fucking hard work. We all do fucking hard work, you know. But to also realize that if you cause enough shit or ask the wrong questions or rub someone the wrong way, as a figure of speech, not literally rubbing someone the wrong way, you will pretty much, you're expendable. Now you have the unions and all this stuff, and it'll be good to get someone in to talk about the union stuff. You know, that'll be really interesting.
Yeah.
But at the end of the day, there are hundreds of nurses out there that are willing to do your job. You know, and that sucks ass. You know, that is some major fuckery right there, man.
Because the thing is, I must say, the team I'm working in at the moment is really good. So I've not experienced any of that kind of.
Not yet.
Not recently, and not yet.
When I become your boss, that's the first thing I'm going to fucking do. I'm going to walk up to your desk. What the fuck do you think you're doing?
Just whack my stuff off my table.
No, fucking whack your head. Bang. But listen, you fuck. Didn't I tell you to make my coffee a flat white, not a fucking long black? What the hell?
But, you know, because there's not as much of that, in our current team that I know of. You know, I actually look forward to coming to work in the mornings. Like I can come to work, I'll make my coffee, I can start the day, and sometimes I feel like I'm making a difference out there, you know, in the community. You and me both have had jobs in the past where you do not look forward going to work.
Oh, easy.
You plow through your job, and you know it kind of breaks your soul after a while. So, you know, mental health nursing can be very rewarding, you know, if that bullying culture is not as prominent, and if you have the right supports and the right team is the important thing. So you can actually do what your true passion is, supporting people with mental health difficulties.
I do think it's getting better. You know, I do think, especially in the last, well, from when I started, I've only experienced that, excuse me, fucking all this Coca-Cola. I've only experienced that one bit. Since then, I've had very positive experiences with a lot of colleagues. I've had professional disagreements with people where it got heated, but at no point was it, you don't know what the fuck you're talking about, fuck off. There's never been that sort of experience for me. Some people argue that there's been elements in the job that we do where people would take advantage or sort of do that. But me personally, I have not experienced that. And maybe I interpret certain things differently than others, but I don't think that I have been bullied since that moment in my new grad year. Now, I have also worked very hard to make myself very intimidating to others. You know, I'm very loud and I'm very in your face, and I will fucking tell you what I think right then and there. But I do it in a way where it's not in a bullying sense, you know, because I don't want anyone else to feel bullied. But I do think it's getting better. You know, I definitely do. This is probably a great opportunity for us to talk about our previous jobs.
Yeah.
Because me and you had some fucking fucked up jobs. Yeah. Sorry to sort of emphasize that, but we have had jobs where it really could have been so different. Who we are as people, and how our lives would have ended up. Did you want to start, or did you want me to start?
I can start. Why not?
Yeah, tell us about your job before nursing.
Yeah, so when I came to New Zealand from South Africa, I ended up in a bakery, working as a baker's assistant, and eventually over time, over a 5-year period, doing a certificate in baking, craft baking, so I'm a qualified baker. But that was a lot more for, at that moment in time, pay the bills, aim was to get residency as well. Then after a while, after that, I wanted to pursue nursing. And at that point, I resigned at the bakery, and I wanted to get all the work I do as a related experience to nursing, to put myself in a better position. So started working in a rest home, which is, full-on care for, older adults. I actually had a lot of job satisfaction there. Working with the elderly, but it was hard work, it was full comfort care, toileting, showering, you're feeding, all those kind of things, but and the pay is not that great.
It's fucking horrible.
Horrible pay, yeah.
It's fucking horrible,
Um,
dude.
So you work long hours with minimum rate. From there, I worked for an addiction rehabilitation facility, which was quite nice, in a sense of it was a well-established area, learned a lot around addiction, and I could actually understand addiction a lot better, which also kind of, because caring, nursing is, basic is caring, which is where the rest time came in a lot. Understanding addiction and how it influences mental health and the people's lives, that was valuable. But from there, started working in as a community support worker for a local NGO, non-government organization, kind of people experiencing traumatic brain injuries, but it was more as a rehabilitation coach. So you kind of help that person with cooking, cleaning, budgeting, shopping, how to access the community. So
Teaching them how to live.
Yeah,
basically.
which is very good.
How to live in society.
Yeah. Lots of, behavioral kind of elements from that as well. And I guess from there, I moved into nursing. Yeah, but doing nursing placements and things. And then,
Yeah. I started, my first ever job that I can remember was working for my uncle in Tonga at the shipping yard, unloading and loading containers from ships. And that was a fucking job. It's not until my later years I look back and I think that was a fucking dangerous job that I was doing. I was unqualified, unskilled, and I was fucking about most of the time. And I am very surprised that I survived the entire thing. So I came here, but I enjoyed it though. It was a fun job. The guys were cool. The guys made it fun. So moved to New Zealand, and my first job here was a community support worker for older adults, where I would sort of look after people in their homes, shower them, give their meds, prepare their breakfast, and get them ready for the day, and then move on to the next one, and then kind of provide cares and stuff like that. But because I was a male, I got all the very difficult ones. So people with quite advanced dementia, who are aggressive, people with PTSD, some gnarly, difficult people out there, but I respect them because they told themselves, I want to live at fucking home, and they are making it happen. They fucking probably can't walk properly. They find it very difficult to shower themselves. They can't cook for themselves anymore, but they are working to keep them. They trying their best, and that was a very traumatic moment, job for me, because as you work in older adults, you deal with a lot of death, and I remember specifically one job. I had a client that he was on my case for like a year, maybe under a year. Fucking deaf as anything. He's so deaf. So like every morning I'd have to go and prepare his medications and stuff like that, and get his meal prepped and get him ready for the day. And then that's kind of where I'll go. And I remember it's not unusual for me to go there and knock on the fucking door and just fucking knocking, because he's deaf. You have to fucking make noise, knocking, fucking like. But this particular day, he wasn't answering, and I was knocking for a good 10 minutes, and I was like, I'll go around the back, knock on his bedroom window. And I was like, oh, this is odd. It's not usual like him. And I kind of walk around, and I look to the living room door, and it's sort of like the living room is those glass doors that you can see in, and the curtains aren't closed. And I was like, oh, that's a bit odd. I'll peer in, and I see my client lying on the ground. It's sort of like half in the living room, half in the hallway. And I'm like, fuck, oh my God, something's obviously happened. I'm knocking and he's not responding. And I'm supposed to know where the spare key is for emergencies. But my mind was so scrambled, and I was so anxious and so sort of like, like, oh my God, I have to do something. I have to do something. Yeah. I fucking kicked down his door. I kicked down the living room door. Fucking glass smashed everywhere. But I was like, fuck, no, I just need to get in there. Kick down the door. His fucking house alarm goes off. And I'm just like, oh my fucking God, get there. I can see he's semi-conscious, but he's not, he hadn't passed away, and I It's cold, and then I I grab a blanket, warm him up, try and get something to, for his head. I call the ambulance, do all these things, called his son. Son rushes over because he lived not too far from his house, and then we're trying to, then all these things, big uproar, neighbors come out, and we're just fucking just trying to deal with this. And then, he gets carted off, and then he gets into the ambulance, and then he goes away. Unfortunately, he passed away about 2 weeks after that. So he had a big collapse, and I think he had some internal bleeding. He must have fallen over, had a cardiac event. But I wasn't really told after. But that was kind of like, it was rare, but it happened more often. So that kind of doesn't make sense. Like, not everyone on my case died, but there was like an understanding that there's a chance that a lot of them can. So he was one of like 6 or 7 people that I was in my care that kind of passed away. A lot of them in their sleep. I'd come in and the family already there, and they say, oh, he's passed on. So, but that was one of the only ones where I kind of shit myself and was just like, oh my God, I needed to do something different. My tolerance for death kind of got to that level. I was like, I can't deal with it, because I got to know them.
And it's the emotion, a lot of the emotions from the family, and as you say, you get to know this person, and
I mean, there's no blame ever came my way, but it was like, I got to know these people so well. Like, they would tell me their history and where they came from and what they did, and what they were when they were younger. They talked about their wives, all these things. And, you build a relationship with them, and then, when they pass on, it's a significant thing, and I kind of was quite tired of that after all, and then moved away and did, pursued nursing, so that was kind of my previous jobs, It wasn't not extensive, but it sucked ass,
For me, the thing is, if I look, all the jobs I've done, the bakery stands out a lot, even though it was not directly related to nursing. But 4 walls, no windows, early starts, hard work, hot environment, same 3 people for the whole day.
Are you sure you weren't working in an inpatient unit? It sounds very much like an inpatient unit, my friend.
But it was just that routine, man. You had a routine of what products, like bread, to bring out at what time. If a person comes at 7 o'clock for the white bread, they want the white bread at 7 o'clock.
Racist. What about the brown bread? There's plenty of brown bread here, bro.
11 o'clock, bro. No.
I want the white bread, brother.
But so you had to do the same routine day in, day out, year in, year out, and that's what got me, because I'm a person that likes diversity. That's what I love of mental health nursing. I'm driving to people's homes, seeing them in libraries, wherever, but
prison cells, Vermont, McDonald's toilets.
Yeah. And I also like that all because, you get a bit of paperwork, so working with a computer, doing phone calls, lots of liaison with other services, and it's ever changing. It's not the same production day in and out. So appreciate the career in baking, but not for me.
No.
Yeah.
No, because I can imagine baking is very stressful. Just having to get up at that time to just prep bread, I fucking hell.
I think that was the monotony that got me.
Monotonous?
Monotonous, that just...
It's the same bullshit.
Same thing day in and day out, So,
I get that. I need variety too. Like
5 years later, I was like...
Wow.
Couldn't remember if I placed salt in the dough. Was it yesterday, the day before, the year before?
Because you just became so good at it, bro. You just kept fucking making 2 different kinds of breads and stuff like that. So, we've sort of discussed a lot of in-depth content, But you know what I actually really want to know? How's your fucking bees, bro? How's your bees? Because
hunkering down for winter.
So,
but they're good.
I want to know, because you just to switch it up a bit, because we've been talking about very intense shit, But you're a prolific beekeeper. It's a hobby that you really enjoy, and you've gone through some shit. Yeah. So I want to know, man. I haven't asked you about your bees in a while. How is your beehives going?
They're going good. Beekeeping, to be honest, is not as easy as I thought when I went into it. Sounds like nursing.
Just fucking winging it, bro. Just fucking winging it.
Bought my first beehive maybe 3 years ago, and I thought I'm gonna have honey for for Africa. I could just see the beehive, see the honey. I'm just
You just see
giving
the
honey,
sea of
selling
honey just fucking floating in your dreams.
Manuka honey, you name it. And then I realized, there's a lot of rules and regulations, but aside that, a lot of pests and diseases that the bees get, and they basically devastate the beehive. So I went from one hive, splitting it, making new beehives, all the way to 5 hives, and then suddenly realizing that I'm losing beehives because I went too quick, too fast, too excited, too green, and so I've got 2 left now.
Shit, and that's 2 from how much was your original colonies?
I had like 5 hives, and also giving hives away at that point.
Right.
But I've slowed down a lot, man. So now I'm just taking it season by season. Lots of learning, YouTube clips. I've done a few courses. But there's so many diseases associated with beekeeping. I couldn't believe it. Like going from bees robbing other beehives, wasps, taking and flying off with your bees, moths invading your beehive, eating your comb. Who knew a bee can't stop a moth,
Yeah, honeybees. Honeybees are not really the most aggressive little bees, are they?
Then you have mites on your bees, and the question is, how do you kill a mite of a mite? How do you kill an insect off
another insect?
So that's the question there. But yeah, so I've just slowed down a lot. So yeah,
I do have to say the last batch of honey you gave me was a hit in the home. Everyone loved it.
That's good. Yeah.
Maybe we start a segment every now and then when you got a new update. We'll hear about LJ's bees. Yeah. Well, listen, I think we've had a lot of great discussions tonight. Very in depth, and hopefully a lot of people will get a lot from this. And we'll leave the rest for another episode, huh?
Awesome, man. Thanks for the assessment.